Welcome to the Heart Disease Risk Factors among African Immigrants Residing in the United States. Our presenter is Dr. Commodore Mensah, Yvonne Commodore Mensah, who is an assistant professor at Johns Hopkins School of Nursing in Baltimore, Maryland, in the Department of Community Public Health. She earned her PhD from Johns Hopkins School of Nursing and BS in Nursing at Fairleigh Dickinson University. Her areas of scholarly expertise and interest include cardiovascular health inequalities, immigrant health, socio-cultural determinants of health. Her career goal is to reduce cardiovascular health inequalities in populations of African descent through community-engaged research. She was principal investigator of the Afro cardiac study, a cross-sectional study examining the association between acculturation and cardiovascular disease risk in West African immigrants residing in the DC area. She was the principal investigator of the Afro cardiometa study, a pilot study assessing the cardiometabolic risk of African immigrants residing in the Atlanta metropolitan area. She is currently the principal investigator of the African Immigrant Health Study, which seeks to identify common health conditions of African immigrants in the Baltimore, Washington, D.C. area. She received the winning abstract award database category at the Preventive Cardiovascular Nursing Association Conference in 2014 and dissertation award from the Johns Hopkins School of Nursing in 2015. She was the recipient of the American Heart Association Martha Hill New Investigator Award in 2016. This is Margaret Corto from the Office of Minority Health Resource Center, and I would like to welcome Dr. Yvonne Commodore Mensah.
Good afternoon, everyone, and good morning to those on the East Coast. Before we get started today, we'd like to take a quick poll to assess your knowledge, and so after the presentation, we'll also repeat that poll to see how well you've retained the content that's been covered. So the questions are on the screen now. If you could please respond.
From breast cancer? Okay.
Next question, please. Okay, great. Thank you so much for your responses. We'll get started with the presentation at this time. The title of this webinar is Heart Disease Risk Factors Among African Immigrants Residing in the U.S. Next slide. I have no financial disclosures. However, I'd like to acknowledge my funding source, which is a KL2 at Johns Hopkins University. Next slide. So the objectives of this webinar are to first describe the sociodemographic profile of African immigrants who live in the U.S. We'll also talk about current research on heart disease risk factors in African immigrants in the U.S. We'll also discuss the role of acculturation in heart health, and lastly talk about clinical and public health strategies to improve the heart health of African immigrants in the U.S. Next slide. So I think it's only appropriate that we start with a definition of heart disease. So heart disease basically involves a narrowing or blockage of the coronary arteries, and which is a blood vessel that supplies oxygen-rich blood to your heart. And so heart disease results from the buildup of plaque. So you can see on the image, on the screen, that when plaque builds up in your coronary artery, it blocks oxygen from getting to the heart. And that's why you may end up with a heart attack. So heart disease is the leading cause of death in the U.S., and it affects men and women equally. So women are more likely to die from heart disease than cancer. However, in the U.S., racial and ethnic minorities are disproportionately affected by heart disease deaths and heart disease risk factors. Next slide. So what are these heart disease risk factors? So on the screen, you see examples of modifiable risk factors, or risk factors that you can actually change to reduce your risk for heart disease. So for instance, if you have diabetes, you're twice as likely to have heart disease. If you have poor health behaviors such as a diet high in saturated fats, or you don't exercise, and you're also obese or overweight, you have a higher likelihood of developing heart disease. Next slide. In the U.S., it is well known that Blacks or African Americans are disproportionately affected by heart disease risk factors. So Blacks are said to have a higher prevalence or likelihood of having hypertension. Blacks are more likely to have diabetes and also be more overweight or obese than their white counterparts. So although personal health behaviors play a role in the development of these heart disease risk factors, there are a number of complex factors such as income, education, genetics, access to care, and communication barriers that contribute to disparities in heart disease risk factors in ethnic minorities. Next slide. But an important question to ask ourselves is, who is Black in America? So skin color has been used as a proxy for race in research, clinical practice, and public health approaches to reducing the burden of heart disease. So this means that one skin color is used to make assumptions regarding the association between race and health. So Blacks in the U.S. are not monolithic. There are different ethnic subgroups within the Black population in the U.S. We have African Americans, we have Afro-Caribbeans, and we also have African immigrants. And so my colleagues and I published a commentary in Ethnicity and Disease calling for researchers and policymakers to change their perspective and not aggregate data on all African descent populations into the Black or African American category, because when you do that, you really mask a lot of differences in these ethnic subgroups. Next slide, please. So in the U.S., the African immigrant population has grown significantly in the past 5 decades. So you'll see from this graph that in the 80s, there were only about 130,000 African immigrants in the U.S. In 2015, the Migration Policy Institute estimates that there were over 2 million African immigrants in the U.S. However, I would argue that this is an underestimation of the true size of the African immigrant population in the U.S. Next slide, please. So African immigrants in the U.S. reflect the diversity of the African continent. So about 35 or 36% of African immigrants in the U.S. come from West Africa, 29% of them come from East Africa, 17 from Northern Africa. And the top 4 countries of origin of African immigrants in the U.S. are Nigeria, Ethiopia, Egypt, and Ghana. And next slide, please. Right, so those are the numbers that shows the breakdown of the African immigrant population in the U.S. Next slide. Okay, so on this map, you'll see that some states are more popular than others for African immigrants in the U.S. So California, Texas, New York, and the D.C. metropolitan areas have the largest concentrations of African immigrants. So if you live in these states, you're more likely to encounter an African immigrant or more likely to care for an African immigrant in the clinical setting. Next slide. In the U.S., the African immigrant population is said to be one of the most highly educated immigrant groups. However, there is some diversity in educational attainment in the African immigrant population. So if you look to the right, under bachelor's degree or higher, you'll see that African immigrants from Egypt and Nigeria are more likely to have a bachelor's degree or higher. However, when you look to the far left, and under the column less than high school, you see that African immigrants from Somalia are more likely to have less than high school education. Next slide. Unfortunately, the relatively high level of education in African immigrants does not necessarily translate into higher income. So you'll see from this bar chart that African immigrants on average earn about $43,000 a year, but that's lower than the general U.S. population, which is about $52,000. However, it's a little higher than U.S.-born blacks or African Americans, which stands at about $33,000. Next slide. Okay, so now let's transition and talk about what we know about heart disease risk factors in African immigrants in the U.S. So very little is known about heart disease risk factors among African immigrants in the U.S., and one of the reasons being that data on African immigrants is usually aggregated with African Americans and Afro-Caribbeans and classified as Black or African American. And so most public health reports and media coverage involving African immigrants have focused on what? Infectious diseases, including HIV, TB, as well as what? Ebola, most recently. And so my colleagues and I wanted to gain an understanding of heart disease risk factors in Africa to help inform our research in the U.S. So we realized that hypertension and diabetes are becoming increasingly prevalent in sub-Saharan Africa. So in rural and urban parts of Ghana and Nigeria, you'll find that hypertension and diabetes are becoming prevalent. So Williams and colleagues also conducted a study to understand the genetic risk for diabetes, and they realized that those from sub-Saharan Africa had the highest genetic risk for diabetes. So imagine what happens when this population migrates from Africa to a highly developed country like the US, and they change their lifestyle. So this has implications for their heart health. Next slide. Okay, so I'd like to share a little bit of research conducted by my colleague, Dr. Ajaman. He conducted a RODM study that basically compared African immigrants, specifically Ghanaians who live in rural Ghana, urban Ghana, to those who lived in Europe, in 3 European cities. So in the top 2 bar graphs, you'll see the prevalence of overweight or obesity, and there's a clear gradient, meaning that those in rural Ghana have the lowest prevalence of overweight obesity. However, those in Europe had the highest prevalence. So the red, orange, and blue bars represent those who resided in Europe. So at the bottom, you see the 2 bar graphs, and that represents the diabetes prevalence. So here again, you see that there's also a gradient. However, the red bar indicates Ghanaians residing in urban Ghana. And you'll see that the prevalence of diabetes, about 9%, is very similar to those who live in Europe, right? For Ghanaians living in urban Ghana, sorry, it's purple. So when you compare that to the red, the orange, and the blue, you see that the prevalence is fairly similar. So we can no longer assume that Africans are generally healthier before prior to migration to the U.S. So this study demonstrates that the healthy immigrant effect, where we assume that immigrants are healthier prior to migration, may no longer hold for current African immigrants. Next slide. I'd also like to share some information on the Africans in Americans study. This is being conducted by a colleague, Dr. Ann Sumner, at the NIDDK. And in this study, she compared African immigrants to African Americans. And she observed that although African immigrants had lower body mass index and waist circumference than African Americans, they were more likely to have undiagnosed diabetes and prediabetes. They were also less likely to be insured than African Americans. So again, this shows that there are some differences between African immigrants and African Americans. And so when you aggregate data on these 2 populations, you really mask the important differences that could be addressed in future interventions. Next slide. Okay, so what accounts for the changes in heart health when African immigrants migrate to the U.S.? Well, changes in diet is one of them. So many African immigrants go from eating injera or banku or fufu to eating those foods in addition to processed foods. They'll start consuming fast foods and foods that are high in sugar and saturated fats. Next slide. So another change that occurs is what? Changes in physical activity. So African immigrants may go from being physically active in terms of transportation for day-to-day activities to leading sedentary lifestyles, because many of them drive to work and drive to school and may not necessarily have to walk. However, leisure time physical activity in sub-Saharan Africa is relatively low. So even though they may be physically active prior to migration, it's not with the intention of exercising for heart health. It's because they have to. Next slide. So these changes that I've just discussed are related to the concept of acculturation. So what is acculturation? It's defined as what occurs when 2 groups of individuals with different cultures come into contact with each other. And then there are subsequent changes in the cultural patterns of both groups. And so, for instance, the dietary change may be a result of acculturation. And so in literature, acculturation is measured with in 2 different ways. The first is using a proxy measure of length of U.S. stay. So it's assumed that the longer you live in the U.S., the more American you are. And there's also a cutoff for determining how acculturated an individual is. And the cutoff is usually 10 years. However, a better way of measuring acculturation is using a multi-dimensional scale. So this means that you don't necessarily have to lose your ethnic heritage or your ethnic values to gain the host values, so the American values. So in line with Berry's bidimensional model of acculturation, there are 4 different outcomes for acculturation. So one is assimilationist. So who is an assimilationist? So an assimilationist is someone who migrates to the U.S. and who may identify more as American than they identify as African. Now, an integrationist is someone who identifies almost equally. You may call that person bicultural. So they feel half African, half American. And a marginalist is someone who doesn't identify with neither culture. So they don't identify as African and they don't identify as American. And the last outcome is a traditionalist. So this is someone who identifies more with their ethnic heritage, so they feel more African than American. So they don't want to let go of their African values. So those are the 4 outcomes of acculturation in Berry's bidimensional model. Next slide, please. Next. Next. Okay, so I'd like to briefly discuss the Afro-cardiac study, which was a study to examine the association between heart disease risk and acculturation in West African immigrants residing in the U.S. Next slide. So the goals of this study were to first characterize the burden of heart disease risk factors. We also wanted to determine the association between social, economic, and cultural factors and heart disease risk. And the last goal of this study was to inform future heart disease interventions and public health strategies in this population. Next slide. So this was a cross-sectional study based in the Baltimore, Washington, D.C. area. We recruited participants from 7 churches, and they had to be first-generation African immigrants born in Ghana and Nigeria specifically. And we used convenient sampling and only included participants who were ages 35 to 74. And they had to be Ghanaian or Nigerian, like I said, and they had to live in the Baltimore, Washington, D.C. metro area, and they had to be English speaking. And we excluded participants who were pregnant or were born in the U.S. or another African country, as well as those who had a medical history of heart disease. And we did that because we used a risk score to determine the overall risk for heart disease, and that risk score is only validated in those who don't have heart disease at baseline. Next slide. So this slide shows the recruitment, screening, and data collection procedures. I'm not going to read each and every step, but an important aspect of the study was health education. So in addition to collecting data from participants, we thought it was important to provide health education to the participants. And so we wrote down all the results on what we call the heart disease report card, which is illustrated on the screen. And so this provided the participants with an opportunity to share the results with their providers. And each participant got a $10 gift card for taking part in the study. Next slide. So here are the sociodemographic characteristics of the participants. We recruited about 253 of them, and the mean age was about 50 years, and more than 60% had at least college education. And like I said earlier, a high level of education in African immigrants may not necessarily translate into high income, because only 36% of them reported having a household income greater than $50,000. And importantly, in this study, only 52% of the participants reported having any health insurance. And this is concerning because of what we know about the relationship between having healthcare coverage and having optimal health. Next slide. So this slide shows the prevalence of the heart disease risk factors that we were interested in, and we compared males to females. So the good news is that only one participant out of the 253 reported smoking. Now, granted, we collected data from churches. It's possible that the prevalence of smoking in the study may not reflect the true prevalence of smoking in the African immigrant population. Now, the bad news is that the large majority of participants, about 90% of them, were overweight or obese. And this is a problem because overweight obesity is a significant risk factor for heart disease. Next slide. Now, I'll spend a little more time talking about hypertension because hypertension is a significant risk factor for heart disease, especially in Blacks. So of the 253 participants, about 98% or 98 people or 40% were hypertensives, meaning they were actually diagnosed with hypertension. And of those hypertensives, about less than 40% of the males were actually taking their medication for their high blood pressure. And this was shocking. However, the males were more likely to have hypertension control than the females. Now, it's not clear why we observed this finding, because you'd expect that if females were more likely to report being treated, they would have better hypertension control. However, we suspect that because of the very high prevalence of overweight obesity in women particularly, this may account for the poor hypertension control in females. Next slide, please. So what about diabetes management? So of the 253 participants, about 60% of them reported that they had ever had their blood sugar measured. And this was pretty striking, considering the fact that these are African immigrants in the United States. So you assume that they have access to screening services. So this suggests that screening for diabetes in this population may be suboptimal, and so we should target our efforts towards improving hypertension and diabetes screening in this population. Next slide. Okay, so now we're going to talk about the results for the association between acculturation and heart disease risk. So like I said earlier, we used two main measures for acculturation. One was length of stay in the US, and the other was using a validated acculturation tool to measure acculturation strategies. And so we looked at the association between the concept of acculturation and heart disease risk factors, poor health behaviors, as well as their overall global heart disease risk. Next slide. So this slide shows a bar chart comparing traditionalists to integrationists. So I'd like to point out that when we classified the acculturation strategies of the 253 participants, the large majority were classified as traditionalists. And as a reminder, a traditionalist is someone who identifies more with their African culture than they do with the American culture. And an integrationist is someone you would call a bicultural person. They identify almost equally with their African and American culture. So you'll see that overall, traditionalists had a higher prevalence of these heart disease risk factors. Next slide. So on this slide, we show the association between the heart disease risk factors and length of stay. Like I said earlier, there's a cutoff for length of stay in the U.S. It's assumed that if you live in the U.S. for 10 or more years, that's when your health starts to deteriorate. But we all know it's not true. But that's the cutoff that's used in the literature. So when we classified the participants, we realized that those who, for males, those who had resided in the U.S. for 10 or more years were 5 times more likely to be what? Overweight or obese. In the same vein, those who had resided in the U.S. for 10 or more years were about 8 times more likely to have a pooled chord equation score greater than 7.5. And this pooled chord equation score is a risk score to determine the overall risk for heart disease. So males who had lived in the U.S. for 10 or more years were more likely to be overweight or obese, and they were more likely to have a higher overall risk for heart disease. Next slide. So for females, we observed that those who had lived in the U.S. for 10 or more years were about 2.6 times more likely to have hypertension. Yeah, thank you. So next slide. So this slide shows the association between acculturation and overall elevated CVD risk. And so excuse the bars that are not properly aligned, but basically each additional year of residence in the U.S. was associated with a higher likelihood of having 3 or more risk factors for heart disease and also having a high pooled chord equation score. However, we realized that integrationists, or people who identified equally with the American and African culture, had a lot lower likelihood of having 3 or more CVD risk factors, and they also had a lower likelihood of having a high pooled chord equation score. Now, this was surprising because you'd expect that if truly longer stay in the U.S. is associated with a higher risk of heart disease, then people who were integrationists, who had lived in the U.S. longer, would have a higher risk for heart disease, and that wasn't true in this study. So people who were bicultural had a lower risk of heart disease than people who were traditionalists or held on to their African culture primarily. Next slide. So in summary, the Afro cardiac study found that there was a high prevalence of heart disease risk factors, in particular overweight, obesity, hypertension, diabetes, but the prevalence of smoking was very low. And also cultural factors, and specifically acculturation, may be associated with heart disease risk in this population. And I also want to point out that individuals who were classified as integrationists, so people who were almost half American, half African, had a lower likelihood of having a high risk for heart disease, and those who held on to their African culture and did not want to adopt the American culture. Next slide. I just want to take a quick moment to acknowledge the research team that participated in this study. They are listed on this slide. The study really took a team effort. I don't want to give the impression that all of the data was collected by me only, but we had a team that went out into the community to collect data for the study. So I just wanted to take a brief moment to acknowledge them. Next slide. Okay, so now, because very little is known about the risk of heart disease in this population, we explored national data sets to understand what's known about African immigrants in general. So I'm going to spend the next couple of minutes talking about social determinants of heart disease risk factors in African immigrants. And so this was an analysis of the 2010 to 2014 National Health Interview Survey. Next slide. So just to go over the methods quickly, this was a retrospective analysis of the National Health Interview Survey, and the data is publicly available. Anyone can access that, the data online. And we pulled the years 2010 to 2014 and looked at hypertension, diabetes, and hyperlipidemia, or high cholesterol, in the African immigrants who participated in the national survey. Next slide, please. So just to go over the sociodemographic information for these participants, we were able to collect data for about 1,600 African immigrants, and the mean age was about 40 years. And so about 74% of them reported having any health insurance. And this is lower than the national reports of health insurance coverage. So in the general population, about 83% of individuals have health insurance. And about 40% of the males had at least college education. About 27% of the females had at least college education. Next slide. So in our analysis, we found that 17.7% of the participants had hypertension, and this is significantly lower than the national prevalence of hypertension, which is about 34%. And about 5.3% were considered diabetic, and about 12.1% reported having high cholesterol. Now, I just want to point out that this is from self-reported information. So it's possible that the prevalence of hypertension, diabetes, and high cholesterol in African immigrants may be higher than these estimates because individuals were asked simply, have you ever been diagnosed with hypertension? Have you ever been diagnosed with diabetes or high cholesterol? So these estimates may not truly reflect the prevalence of these risk factors in the African immigrant population. Next slide. So here we wanted to understand the social determinants of heart disease risk factors, and we sorted the data by sex. So for males, we observed that males who were married had a lower likelihood of having hypertension, right? And for the outcome of diabetes, those who had health insurance were more likely to report a history of diabetes. And also for the outcome of diabetes, those who had more than college education had a much lower likelihood of reporting that they were diabetic than those who had less than high school education. So for the outcome of high cholesterol, again, those who were married were less likely to report having high cholesterol. However, those who had health insurance, again, were more likely to report being diagnosed with high cholesterol. Now, you may say that you'd expect the odds ratio to be lower. You'd expect people who have health insurance to have a lower likelihood of being diabetic or having high cholesterol. However, we believe that the odds ratio is actually higher because these individuals are being diagnosed. So this just indicates that if you have health insurance, you're more likely to be screened and diagnosed for hypertension and high cholesterol than those who don't have health insurance. Next slide. For females, we found that, again, those who had health insurance were more likely to be diagnosed with hypertension than those who did not have health insurance. And the other social determinants that we examined in females were not significant. So only health insurance played a role in predicting the prevalence of heart disease, of hypertension in females. Next slide. So in summary, from the analysis we conducted on the National Health Interview Survey, we observed that for hypertension, being married is actually protective. So for males, if you're married, you have a lower likelihood of having hypertension. However, if you have health insurance, you're more likely to be diagnosed with hypertension, which is a good thing. We want individuals to be diagnosed. And for the outcome of diabetes, again, health insurance was associated with the higher odds of being diagnosed with diabetes in males. And having higher education was associated with a lower likelihood of being diabetic. And so for the outcome of high cholesterol, again, if you're married as a male, you're less likely to have high cholesterol. However, if you have health insurance, you're more likely to be diagnosed with high cholesterol. Next slide. Okay, so given everything we've discussed so far, what are some public health strategies we can implement in the African immigrant population to actually improve their heart health? Well, first of all, we need to gather additional data on African immigrants in the U.S. There's very little published information about the prevalence of heart disease risk factors in the African immigrant population. And we also need to increase the awareness that the demographics of the African immigrant population is also changing, right? And so individuals migrate to the U.S. for different reasons, and some may be fleeing conflict in countries such as Somalia. And so African immigrants in the U.S. reflect the diversity of the African continent. So not everyone is highly educated. We also need to identify ethnic enclaves in the U.S. So for instance, African immigrants who live in New York versus the Baltimore, Washington, D.C. area or California. And identifying those ethnic enclaves may help us to actually develop community-based programs to promote heart health and reduce cardiovascular events in this population. And we also need to advocate for improvement in health services for this population. So a lot of health services that are available to immigrants in the U.S. are tailored to the Asian immigrant population and the Hispanic population. So rarely will you find health services that are tailored to the African immigrant population. So that's one of the things that we need to change if we need to improve the health of African immigrants in the U.S. Next slide. So for clinical strategies, we need to keep in mind the following things. So health literacy. So health illiteracy in African immigrants may lead to medication errors and poor health management. So if we don't remedy health illiteracy, this may lead to drug overdoses, or participants may not be able to communicate their concerns to their providers. And the other thing to keep in mind is that in many African cultures, there's a paternalistic relationship between providers and patients. So healthcare providers may be seen as authority figures, and may not, and so patients may just nod or smile to indicate polite deference. So you actually have to make an effort to engage patients in their care and ask the right questions. And so African immigrants may also have limited family history. So if you may ask an African immigrant, what was the cause of death of your grandfather or your father, some of them may not have that information. They may just simply tell you that they died suddenly, but you may not be aware of whether they died for cardiac reasons or other reasons. So they may have very poor family or health history. And so the other thing to keep in mind is that African immigrants may take herbal or alternative medications from Africa. And so you also need to assess this in your interactions with patients. So they may be taking other medications that are supposed to cure about 5 different diseases. And if you don't ask the right question, you may not know if you're actually taking these medications. And they may actually discontinue their prescribed medications and take some of these herbal or alternative medications that are sent to them from Africa. And the other thing to keep in mind is that mental health may be a serious issue in this population. So many African immigrants may communicate disappointment upon arriving to the U.S., and they may be stressed out because they are disconnected or isolated from their family members in Africa. So that's something to be aware of and to address in your interactions with patients. Next slide. Okay, so as Margaret said earlier, we are currently conducting the African Immigrant Health Study in the Baltimore, Washington, D.C. area. So this study is open to participants who are born in Cameroon, Ghana, Liberia, Nigeria, or Sierra Leone. And so we are simply administering a survey to understand their sociodemographic background, their health history. We also want to understand cultural preferences in this population. And we're also asking about stress, discrimination, resilience, among other measures. And so there are no invasive procedures in this study. We're simply also measuring blood pressure, height, and weight. And so to participate in this study, you have to be at least 30 years old. You have to live in the Baltimore, Washington, D.C. area. And then we also give all participants a $10 gift card for completing the study. Next slide. Okay, so if you'd like to contact me, my contact information is provided on the screen. My email address is ycommod1@jhu.edu. My phone number is also provided on the screen. So I think we'll take questions at this time. Thank you.
No questions. How many people are registered?
No, you weren't, because I thought you were going to ask.
Okay, Dr. Commodore, here's some of the questions that we have. What about those who are not traditional English speakers? Are there any plans for research for them too?
Yes, that's a very good question. And so what I failed to mention during my presentation was that the Afro cardiac was conducted as part of my dissertation work, so resources were very limited, and we had hoped to include African immigrants from French-speaking countries, for instance, because not everyone may speak English. So because of limited resources, we limited the sample to those who are English-speaking. But the goal of the African Immigrant Health Study is to gather sufficient pilot data to apply for grants that will allow us to hire individuals to help us conduct the study. And so we'll be able to include African immigrants from, for instance, French-speaking countries or those who may not necessarily speak English. But thank you for that question, and it's something we are planning to do in the near future.
Okay, thank you. The other question is, did you consider that some West African immigrants, especially Nigerians, might have been born and lived in the United Kingdom and then relocated to the U.S.? Does that change their health outcomes? And that's from Adibola.
Yes, thank you for that question. So in my presentation, I said that there were three main groups of African ethnic groups in the U.S. So those who were born in the U.S., those who were born in Africa and the Caribbean, but there are also Africans who migrate from Europe to the U.S. And so the picture we have on African immigrant health in the U.S. is maybe similar to African immigrants in Europe. So from Dr. Charles Ajiman's study, we can see that the prevalence of heart disease risk factors is also high in African immigrants in London. I didn't spend too much time on that, but the prevalence of hypertension, diabetes, overweight, obesity is also high. So for those individuals migrating to the U.S., their risk for heart disease may be equally high, right, or higher than those who may be migrating directly from Africa to the U.S. But that's a very important question, and in the future, we should also clearly delineate those who are migrating from Africa or other more developed regions of the world.
Okay, thank you. The next question is, may I know if you measure the spiritual or religious experience of these African immigrants? as this may influence their health-seeking behaviors and lifestyle? This is from Hawa Abu.
Thank you for that question, Hawa. We did not administer an instrument to assess their spirituality. However, most of the participants, or all of the participants, were recruited from churches. So one limitation of the Afro cardiac study is that it may not necessarily reflect the health of the general African immigrant population. And so churchgoers may be very different from those who don't go to church. They may be more likely to underreport smoking because smoking is considered a socially undesirable behavior in many African countries. So if someone actually smokes, they may not be truthful if they're asked in a church setting. And so that may be one of the limitations, but we did not assess spirituality in the participants. But because they were all church attendees, our assumption is that they're highly spiritual, and however, this may be a limitation in terms of generalizing the information to the larger African immigrant population.
Well, thank you. This is my question, then I'll go for another question online. One of the things that I've seen that we do a lot is when we talk about the church and Christianity, while the continent, I think I've heard there are more Muslims on the continent. So as you're doing this and you're actually going to the churches, have you considered some of the mosques and how to reach the Muslim population within the African community?
Yes, thank you very much for that question. So one of the reasons why we are conducting the African Immigrant Health Study is that in the previous Afro cardiac study, we only recruited participants from churches. And so we want to expand and also recruit African immigrants from mosques in the Baltimore, Washington, D.C. area. So I actually just recently connected with someone who is a member of a local mosque in the Silver Spring area who is going to help us get connected with the leaders to help us to collect data from this population as well. But that's a valid concern, and that's something we're working on in the African Immigrant Health Study.
Wonderful. Another question is, I'm currently working in diversity programs at the Clay County Public Health Center. We do invite guest speakers to talk about diversity, minority health, their access, and barriers to healthcare in the U.S. Is this something you would be interested in? We are located in northern Kansas City area, and this is from Oyun Diary.
Yes, sure.
It's a job offer.
One of the things I'm passionate about is actually presenting to community-based groups and churches on this topic, and also nonprofit organizations which may serve the African immigrant population. So if you can please connect with me offline, my email address is provided on the screen. I'd be happy to talk to you about that in more detail, but I'd be happy to.
Okay, would this be the last question? It's from Ruth Alma. She says, thank you. What is the progress on trying to differentiate African immigrants from African Americans when collecting information in surveys, for example?
That's a very good question. And so one of the reasons why data is not disaggregated for African descent populations is the relatively smaller size of African immigrants in the U.S. So, for instance, for the census, right, individuals are asked to identify as Black or / African immigrant or African American, but they can also indicate their country of origin, right? And so many people opt for just Black or African American and don't necessarily check off other and indicate their country of origin. And so I think we also need to push for changes in reporting data on African descent populations, right? And the decisions to report data on African immigrants versus African Americans versus Afro-Caribbeans is made by the Census Bureau. So if they get enough requests or pleas from researchers and community-based organizations to to change how they report data, I think that would definitely make a difference. But the census reporting of ethnicity and race in the U.S. really drives how research is conducted also. And for researchers in the community who are also recruiting participants in their research, when they say they want to understand, for instance, hypertension in blacks, an African immigrant may not necessarily respond to that, right? Because they identify as African. So if you really want to understand the health of African immigrants, I wouldn't say seeking to understand hypertension in blacks, because even though they share the same skin color, they don't identify as black or African American. So thank you for that question, and we are hoping that with additional research conducted in this area, it would put enough pressure on the powers that be to change how data is reported on African descent populations.
Thank you so much, Dr. Commodore. We've come to the end of our presentation, and I think the last question is something I've been talking about for almost 14, 15 years now. As a population, if we want the data changed, then we have to make the effort and put in, not checking African American and put in whatever black, African, whatever it is that you want to be known as. And if enough of us do that, that might change. So thank you all for joining us. We appreciate your time. Thank you. And thank you, Dr. Commodore.
Thank you. Are we going to administer the poll?
Yes, we have a few minutes for that. Thank you for reminding me. Please, if you take the few seconds to, she wants to see the pre and post poll. It's going to go up in a few seconds.
Good afternoon, everyone. Unfortunately, this is the technical end. Unfortunately, we just realized that we can't actually run the poll again, because once the answers are recorded, they cannot be recorded again. So I do sincerely apologize for that, Dr. Commodore.
Oh, no problem. Thank you very much. Thank you all for attending.
But thank you, everyone, for participating at the beginning. And thank you very much for joining us today. Again, this presentation has been recorded. A recording will go out within 24 hours of when we end this webinar right now. If anyone would like a copy of the slides, you can send us an email at info@minorityhealth.hhs.gov. Our email should also be in the follow-up email that you will receive. Our email address will also be in a follow-up email that you will get with the recording. Thank you very much again, Dr. Commodore, for being with us today, Dr. Commodore Mensah, Margaret, and to our audience. Have a great day, everyone.
Thank you.
You're welcome.
Thank you, Maria.